Welcome to the Lymphoma Research Foundation's update on chronic lymphocytic leukemia, small lymphocytic lymphoma webinar. I'm Osman, and I'll be the operator for today's call. During today's call, you will hear from an expert speaker, and you will have an opportunity to ask questions. If you have questions during today's presentation, you can ask that at any time in the Q&A box on the webinar. As a reminder, this webinar is being recorded. At the end of the program, a link will appear on your screen. Please follow this link to complete an evaluation of this program. If you are listening by phone, this link will be sent to your email at the end of the webinar. And now I'm pleased to introduce Jesse Brown. Jesse Brown is the Associate Director of Patient Education at the Lymphoma Research Foundation. Welcome, Jesse.
Thank you. And thank you to each of you for taking the time to join us on today's update on CLL, SLL webinar for newly diagnosed patients. We'd like to thank our sponsors of this webinar, AstraZeneca, Genentech, and Pharmacyclics. Before I turn the program over to our speaker, I want to briefly share information with you on the Lymphoma Research Foundation. Access to expert disease information is so important, and we're thrilled to be able to bring you this educational program. LRF is the nation's largest nonprofit dedicated exclusively to lymphoma. Our mission is to eradicate this disease through investment in the most promising lymphoma research and to serve those impacted by lymphoma through quality education and support opportunities. As we continue to make progress in advancing lymphoma research, we also want to ensure you have access to the latest information about your disease. The Foundation provides comprehensive disease and treatment-specific resources, programs, and services, all of which are offered free of charge and have been reviewed by lymphoma experts. Most relevant to today's call, LRF offers a variety of lymphoma-specific resources, many of which you can access at the bottom of your screen if you're utilizing the web link, or via LRF's website at lymphoma.org if you're on your phone. The LRF Helpline can answer your specific questions about lymphoma, as well as discuss relevant treatment options and clinical trials. We also offer the Lymphoma Support Network, which is a one-to-one peer support program for people with lymphoma and their caregivers. We offer a variety of publications that have been reviewed by lymphoma experts to ensure you have access to the latest lymphoma information. Our mobile app, Focus on Lymphoma, is an award-winning app that provides patients and caregivers access to comprehensive content, as well as unique tools to help manage your disease. To learn more about these CLL, SLL specific resources, or if you have questions regarding what you heard about today, you can reach out to the Lymphoma Research Foundation through our website at lymphoma.org or by calling our helpline at 1-800-500-9976. We have a wonderful program planned for you today, and I'm honored to introduce you to Dr. Deborah Stevens. Dr. Stevens is a hematologist and oncologist at the University of Utah Huntsman Cancer Institute, where she's an assistant professor in the Division of Hematology and Hematologic Malignancies. Thank you so much, Dr. Stevens, for speaking at our program today. I'll now turn the talk over to you.
Thank you so much for the introduction, and I'm really honored that there's so many of you here today to learn more about your CLL or SLL. I think it's really important that patients take control of their disease and they understand what's happening, and I really want to give you an introduction today and then give you plenty of time to ask questions that you may have based on the presentation or questions that you have right now before learning more. The agenda of my talk today involves just an overview of chronic lymphocytic leukemia and small lymphocytic lymphoma, a look at current treatment options, including the management of side effects, which is very important, and a sneak peek at new and emerging treatment approaches for CLL. Starting with the CLL and SLL overview. So very basic, what is CLL or SLL? When I think of it truly as a blood cancer. And when you think of blood, there are three main solid components. Over on the left-hand side, you see that there are red blood cells. Of course, they are there to carry oxygen around your system. And a low red blood cell means that you have anemia. In the center, the next solid component of blood are platelets, and platelets are what helps you to make blood clots. Low platelet counts are called thrombocytopenia. And then, very importantly, over on the right-hand side, you have white blood cells. White blood cells are key portions of your immune system. They're there to help you fight infections. And of course, CLL or SLL is a cancer of a type of white blood cell. Here I have pictured all different types of white blood cells, and over on the right-hand side, there's a cell called a small lymphocyte. And lymphocytes are normally there to help fight infections, especially viruses. And so specifically, CLL or SLL is a cancer of these types of small lymphocytes, so a type of white blood cell cancer. So I'm often asked, what is the difference between CLL and SLL? Well, actually there's not a lot of difference between it. It really depends on the location of where you're finding these cancer cells. So chronic lymphocytic leukemia typically means that you have a high white blood cell count, and you have to have more than 5,000 of these cancer cells circulating around in the blood. As opposed to circulating around in the blood, SLL, or small lymphocytic lymphoma, means you have a lower white blood cell count, so the cancer cells are mostly found in lymph nodes or the spleen. I think it's very confusing for people to be told that you have either leukemia or lymphoma, and so when I refer to it, I really just refer to all of it as CLL. And when I talk about it, I use this couch analogy, and maybe this makes sense to you. I think of cancer cells as a couch, and your body is a house. And if you move that couch to a different room in your house, it is still the same couch. And so really CLL and SLL, they're really the same thing, just found in a different location. And really all the treatments are very much the same. So when we talk about treating CLL, it's a little bit different than some types of cancers that you may have heard of, where they are treated right when you get diagnosed. With CLL, since it is a slower growing type of cancer, and we do not have a cure yet for CLL, we only treat for signs of active disease. And so this is when the CLL affects your other types of cells, like your red blood cells causing anemia, or platelets causing them to be low. If you have symptomatic, so pain or other symptoms related to an enlarged spleen or lymph node, that might be an indication to treat CLL. Or if you have what we refer to as B-type symptoms, so that really is considerable weight loss, fevers for 2 weeks without a sign of infection, drenching night sweats for a month without a history of infection, or severe fatigue. And of course, most of the people who I talk to that have CLL have experienced some level of fatigue. And that's probably one of the most draining things about this disease, is that fatigue can become unmanageable and require us to actually treat the CLL. So what about the people who don't get treatment for their CLL right at diagnosis? Well, this is a category that we often refer to as watch and wait. However, sometimes people refer to it as watch and worry. And the reason why is because sometimes it makes people feel pretty uncomfortable not to treat the cancer when it is diagnosed. However, the reason why we do this is, as of right now, no treatment has been proven to lengthen survival, so number of years of life, when given early. Meaning, treatments have been tested right at diagnosis versus waiting until time of symptoms, and both of them have similar survival times, meaning we're not changing the natural course of the disease by doing treatment earlier. Now, I just make a note here because a lot of these studies have been done with our old chemotherapy drugs, such as chlorambucil and fludarabine. And I'm going to talk about an ongoing study for early treatment later in this talk that involves some of the newer drugs. What's important is to understand the goals of CLL treatment, because at this time, there is no cure for CLL except for a bone marrow transplant. And bone marrow transplant is a really aggressive procedure that doesn't always work. And it's hard because a lot of the people who get diagnosed with CLL, they may be older when they get diagnosed, have other health problems. Doing a bone marrow transplant is just too toxic of a procedure to do. And so the main goal of our current treatment is to get people into remission. And what that means is no evidence of active CLL. And of course, we want to do this for the longest time possible. And so when you get treatment, your doctor may quantify how well you have responded to treatment. And that could be something called a complete remission, which means you have normal blood count, normal size lymph nodes and spleen. You could have something called a partial remission, which means you've at least had a 50% reduction of your white blood cell count, lymph nodes, and spleen size. Or stable disease, essentially no change since you started treatment. Or progressive disease, meaning you have new areas or worsening disease. And the topic that comes up quite a bit now is called minimal residual disease. So what exactly is that? So minimal residual disease is a method that we use to detect really small levels of CLL. This could be done by flow cytometry, which I've shown a little cartoon over here on the left that indicates how we do flow cytometry, or sequencing. And so basically we're sorting all your cells and determining, can we find a tiny, tiny number of these cells still? You might hear some people say, are you MRD negative? Essentially, I like to say MRD undetectable, because it means we can't detect the disease. It might still be there, but it's just a small amount that we can't detect it by our current methods. So CLL patients who are able to achieve undetectable minimal residual disease after certain treatments do have a longer survival and a longer time till next treatment. And so some of these I'll refer to some of the treatments where this is important later on in the talk. I've really been asked to highlight some of the current treatment options, and again, I want to include some of the side effects along with this, so you know that what could be an option in terms of treatment options, because really what you want to do is you want to pick the best treatment option for you that has the best results in terms of putting your CLL into remission, but also has the most manageable side effects. All of these are really important when making a decision for first or subsequent treatment of CLL. So general cancer treatment options don't always apply for CLL. And so I've just included a note that surgery is often not recommended. Of course, we might have to do a surgery to diagnose you, like a lymph node biopsy. However, we can't treat through surgery because it circulates around in the blood. And so we wouldn't be able to take it all out, unlike other tumors. Radiation is also very rarely used for CLL. It's only used when we can't get a response and we really need just an area that is causing a lot of issues. Like, for example, if you were to have a lymph node in the throat that just needs radiation to shrink that down so that we can move forward with treatment. Honestly, I find that it's very, very rare that I use radiation for patients who have CLL, and probably in the last 8 years, I can think of one patient that we did it as kind of an emergency situation. So chemotherapy, or drugs that pass into your blood and are spread throughout your blood, is the usual choice. And so that just makes sense for blood cancer because your blood is circulating everywhere, so you want a treatment that reaches all of those cancer cells. So we often refer to classic chemotherapy, immunotherapy, and targeted therapy. So I want to go through a little bit about what that all means. So when I refer to classic chemotherapy, these are drugs that they go in and it's kind of non-specific killing of growing cells. And so that means, usually your cancer cells are growing a little faster than your normal cells. So it does kill your cancer cells to a greater extent. However, normal cells will get killed as well. And so this is really non-specific killing. And what happens is the body goes through a process where it looks at all the dead cells and it says, are these cells we need to repair, which are good cells, and it lets them grow back? And are these cells that we don't want to repair, like cancer cells, and keeps them dead? And so essentially some of the examples of this kind of treatment are fludarabine, cyclophosphamide, bendamustine, pentostatin, or chlorambucil. All of these are pills all of these are IV therapies except for chlorambucil, which is a pill. Kind of generally, and some of these are more specific depending on the actual treatment you get, but short term, you can have nausea, hair loss, fatigue, low blood counts, infection, nerve pain or neuropathy, rash, blood in your urine, or even heart failure when using some of these agents. Long term, they can cause bone marrow damage. So that bone marrow damage can lead to something called myelodysplasia or even acute myeloid leukemia. And so really there have been a lot of head-to-head studies that look at these classic chemotherapy agents compared to our newer agents. And we have found that the newer agents work just as well or maybe better and have fewer side effects. And so at this point, these drugs are actually pretty rarely recommended just due to the side effects and all the availability of other new options that we can use. The next class of chemotherapy is really immunotherapy. And a lot of this looks at specific targeting that's something that lives on the surface of a CLL cell. So a lot of these are antibodies. You guys have probably heard the terms before. Rituximab, ofatumumab is one that is not commonly used anymore, but obinutuzumab is very commonly used. And basically these are manufactured antibodies that they have a part on them, the top part that recognizes the cancer cell. In the case of these antibodies, it recognizes something called CD20. And it either kills the cell directly, or the part on the bottom of this antibody over in the graphic is what tells the other immune cells to kill the cancer. So it says, you know, immune system, wake up and get rid of these cancer cells. Targeted therapy is really the topic of a lot of discussion right now. And the point of targeted therapy is you want to avoid killing normal cells and goes after something specific to the cancer cells. All these medications I've listed here are pill medications, and they include ibrutinib, acalabrutinib, zanubrutinib, idelalisib, and venetoclax. But there are others in different stages of study right now. First, I want to talk about the drugs called Bruton tyrosine kinase inhibitors, or they might be referred to as BTK inhibitors. Essentially, with this kind of drug, it's based on the fact that there's something called the B-cell receptor signaling pathway. And this is not working very well in folks who have CLL or SLL, because what it's doing is it is sending these signals to tell the cancer cells to stay alive. And so what BTK inhibitors do is they block those signals. And so I think of it like taking the gas out of your car. So the drugs that we have available right now are ibrutinib and acalabrutinib. These are approved by the US FDA for marketing to all patients with CLL or SLL. There's another drug called zanubrutinib, which is likely going to be approved for CLL soon. It's already approved for some other types of lymphoma, and so likely that approval for CLL is coming, and we'll have even more options to talk about. I wanted to highlight a couple of common toxicities with BTK inhibitors, and you know, one thing to note about these drugs is when you start on them, they're meant to be taken indefinitely. What that means is, you know, sometimes people say, "Doc, does that mean I have to take this drug forever?" Well, maybe, but I don't really think about it that way, because we take them until, you know, if the drug stops working, you would stop that medication. If you have side effects that are not tolerable, of course, we would stop that medication. Or, you know, if as the field develops and something new comes along that's better, then we would stop this treatment and start a different treatment. But things to be aware of, because you're going to be taking these drugs long term, is there are some side effects. And some of them, it's important to note things that go away with time and things that can always happen. Because, you know, usually during the first month or two is when people would be most likely to discontinue these drugs for side effects. However, it's unfortunate because after a patient is on these drugs for 3 months or so, usually those side effects will actually go away on their own without stopping the medication. A couple that I've highlighted here. So in gray, these are the ones that I consider early side effects, and they usually go away with time. And those include arthralgia or joint pains, infections, and diarrhea. So those are all things, again, if we can get you supported through the first couple of months, usually people can tolerate these drugs quite well. There are side effects that do increase with time, so I put those in the light blue color. These are things that we should always be aware of. There is a irregular heart rhythm called atrial fibrillation, which can happen, and happen quite commonly with these drugs. And what people usually experience is a sensation of fluttering of their heart or shortness of breath that wasn't there before. These can be very easily managed in terms of giving medications to slow down the heart rate, but might require you to start a blood thinner so that you don't have a stroke from this irregular heart rhythm. That becomes a problem because bleeding is also a side effect seen with BTK inhibitors, and so bleeding and bruising can be quite common. as I've highlighted here in the darker blue, that bleeding is always a risk. The other effect that I want you to be aware of is high blood pressure. Your doctor should be checking your vital signs whenever you come into the clinic and paying attention if your blood pressure gets too high. You might have to start on blood pressure medications to lower this. Of course, there have been some recent studies that have compared these different BTK inhibitors to each other and have found that there is less toxicity with acalabrutinib or zanubrutinib than with ibrutinib. And so, if you're experiencing side effects that won't go away on ibrutinib, there might be an opportunity to switch over to acalabrutinib. I wanted to include some key points that I use to manage these toxicities, and starting with the early toxicities. So arthralgia or joint pain, often Tylenol or a short course of oral steroids can help with this joint pain. And again, just getting you through to the point where your body is used to the medication and you wouldn't need these treatments anymore. Myalgia or muscle cramps often goes along with that. It's very important to maintain hydration, so drinking lots of fluids, stretching, especially before going to bed. Pickle juice or other, salty beverages can also help with these muscle cramps. Some patients tell me that magnesium supplements do help. You have to be a little bit careful with the magnesium supplements because sometimes they can cause diarrhea, which is the next side effect that I have listed. So diarrhea can happen. And if you're having more than 7 episodes of diarrhea in a day, that's considered severe, and you really should be checking in with your doctor so that they can check for infection and determine whether anti-diarrhea medication or holding your treatment would be an important factor here to help you manage that diarrhea. Headache is one that I see more commonly with acalabrutinib, again, just during the first few months, and Tylenol or increased intake of caffeine is often very helpful with this. I wanted to highlight managing the later toxicities with BTK inhibitors, including this atrial fibrillation, rapid heartbeat. I often need to have a cardiologist consult, and there's a lot of different methods that we could do to slow down the heartbeat. Again, likely need blood thinners, but not warfarin or Coumadin because it interacts with BTK inhibitors. And so it's a little bit more of a complicated management, but it is not unmanageable, and we can often get people through this. Often people stay on the drugs even when they have atrial fibrillation. Again, high blood pressure can happen, and blood pressure medications could be needed. Bleeding and bruising is a side effect that is seen throughout the treatment, and I always counsel my patients to make sure that they hold their drug before and after elective surgeries. So like, for example, if you're going in to have your knee replaced, I would tell people, in the case of ibrutinib, I would tell people to hold that drug for 7 days before and after that big of a surgery. For acalabrutinib, you just need 3 days before and after, but really just check in with your doctor if you're going to have a surgery, and they can help to guide you on this. I put a box down here to say drug interactions are possible. So if one of your other doctors decides to start you on a new medication, please consult your oncologist to make sure that doesn't interact with your BTK inhibitor. I do want to say, just because drug interactions is a big deal, the drug called acalabrutinib has just come out with a new formulation. So there's many people who get heartburn, also called reflux or GERD, and they take medications like omeprazole to block acid. And the original formulation of acalabrutinib, it really needs that stomach acid to digest the drug. And so doctors are counseled to take their patients off of these drugs before they start treatment with acalabrutinib. However, this new formulation that's coming out doesn't require the stomach acid to digest the drug, and the new formulation is available in some places. So if you have issues with heartburn or reflux, you might want to ask your doctor if you could switch over to this formulation so that you can use a more effective acid blocking drug. I'm going to spend a little bit of time talking about venetoclax. It's a lot different than the other drugs in terms of it has a different mechanism or the way it acts. So I've tried to show a graphic here, kind of like a seesaw. And what happens in CLL or SLL cells, they increase this protein called BCL2. And the goal of doing that is to live longer. And so that keeps those cells just living long term. And that's what I'm showing here on the left-hand side. But what venetoclax does is it comes in and blocks that BCL2 protein, and it promotes cell death. So it kind of tips that teeter-totter over into causing the cancer cells to die. So different way that it works, but highly effective medication. I wanted to highlight some of the toxicities and how I would manage these toxicities. And when you're started on this drug, your doctor would talk about something called tumor lysis syndrome. Well, essentially what that means is your cancer cells are breaking down, and they're breaking down fast. And what they do is they put all these waste products out in the system, like potassium or uric acid. So you need some preparation before you start venetoclax therapy, and that you need to keep hydrated. You might need drugs like allopurinol that prevent uric acid buildup. Some people that have really high white blood cell count or large lymph nodes might need to be hospitalized to be monitored during that time. It's really important because some of these waste products can cause heart abnormalities, heart arrhythmias, or if your kidneys just can't handle this big load of waste products, then dialysis might even be needed. And I find that to be very rare if you prepare, meaning hydrate, using these drugs like allopurinol to prevent uric acid buildup. Other things that can happen with venetoclax include GI effects like diarrhea and nausea. Anti-diarrhea and nausea medications are often helpful. I often counsel my patients to take the dose of venetoclax at night because that is usually helpful at dealing with the nausea portion. Sometimes these drugs can cause low infection-fighting white blood cells or neutrophils or low platelets. Your doctor should be monitoring for this. If your good white blood cell counts are low, you can get growth factor injections such as Zarxio, Neupogen, Neulasta. If you do have infections, or some of these drugs like venetoclax can cause a lack of vaccine response. And so, especially in this time of COVID, it's important to kind of plan ahead with your doc. And if you're planning to start treatment, it might be useful to make sure you're up to date on your flu vaccine, up to date on your COVID vaccines. Of course, if you do get an infection, your doctor will need to help you with antibiotics. So when we talk about these two different strategies to treat CLL, we're really looking at the BTK inhibitors. Kind of their goal is disease control. So it's kind of treating your CLL like a chronic disease like diabetes or hypertension. And these can lead to really prolonged remissions. Or we have fixed durations. So for example, in frontline treatment of CLL, we use a combination of venetoclax and obinutuzumab, and that venetoclax therapy is only for 1 year. The goal of this therapy is disease elimination, a more deep remission, and to get undetectable MRD. Now, interestingly, these two groups of drugs, they just really have different strategies, but they're both highly effective. And so I think the important point to remember when you're deciding a treatment is these therapies are so good at treating CLL, and we can work with the side effects if they occur, that either choice is often good. And you should really discuss this with your doctor, and that's called shared decision making. If you want to make sure that the benefit of the drug outweighs any potential risks or side effects of the drug. I wanted to spend a little bit of time talking about new treatment approaches because we have a lot of exciting things that are coming through in the field of CLL. And one of those are just combinations of these new drugs. And so the concept is, if one drug is good, is 2 drugs better, and is 3 drugs even better? And so you're really picking, 2 or 3 of these drugs and combining them. So picking a drug like a BTK inhibitor, plus a BCL2 inhibitor like venetoclax, plus anti-CD20 monoclonal antibody. So maybe some advantage to this are, maybe could we get deeper or longer lasting responses, or could it shorten the treatment length? For example, we usually say when somebody's starting on ibrutinib, that you're going to be taking it indefinitely. But if we combine it with venetoclax and get a deeper response, could we limit that treatment to just 1 year or 2 years of treatment? Of course, something to consider is when you add more drugs together. I just talked about a bunch of side effects that can happen with each of these drugs, and it's possible that those side effects could be worse on combination therapy. And so again, there's a lot of studies out there. I'm going to highlight a few, but just looking at, is it worth the risks or side effects to combine these drugs. There's a really important study that's ongoing called the Captivate study. And this is for patients who have never been treated for CLL, but they do require treatment now. This is specifically for patients who are under the age of 70. The treatment that they receive is that BTK inhibitor ibrutinib for 3 months, and then they combine the two pills, ibrutinib and venetoclax, for 12 months. If people are able to achieve that MRD undetectability, they are randomized to either continue receiving ibrutinib or placebo. And then if they aren't able to achieve that undetectable MRD remission, they are randomized to continue one drug, ibrutinib, versus 2 drugs, ibrutinib and venetoclax. So importantly, in that top arm, in this MRD undetectable, so far they have reported that they have found no difference in the disease-free survival rate after 2 years, meaning that patients who were able to achieve that deep undetectable MRD remission, they were able to maintain just about the same amount of disease-free survival whether you gave nothing, meaning placebo, or whether you continued treatment. So that's a really important message because you could save yourself, the cost and the side effects of ibrutinib if you're able to achieve undetectable MRD remission. When people are found to be MRD detectable and randomized between the two, the responses did become deeper if you continued both of the drugs. And so, maybe if you still have disease, you would still have a chance of getting rid of all of that disease by taking both of those. What to know? So the drug is not yet approved, and these 2 drugs are not yet approved in combination in the United States, so they're only available together on a clinical trial. However, there was a study called the GLOW study that was run in Europe that has allowed this combination to be approved in Europe. So it likely is coming soon in the United States. And so again, worth discussing with your doctor whether this might be an option or might be recommended for you. However, one thing to note is the GLOW study did allow for patients who were 65 and older only to enroll on the trial. Definitely there was more toxicity with the combination in patients who are older than age 65. So again, something to keep in mind of, whether do we need one of these drugs? Do we need 2 of these drugs? Or, what's the best way to use them? That's what a lot of trials are trying to figure out right now. What's unclear is if this ibrutinib venetoclax combination is better than some of the other options. And there's a study that's ongoing in Germany right now called the CLL 17 study. And that will help us to understand, if this particular treatment, the ibrutinib venetoclax combination, is better than some of the other novel treatments that we're using. I mentioned the drug zanubrutinib that's not quite approved yet. I think this is an important drug because they're specifically studying the combination of zanubrutinib and venetoclax for patients who have a high-risk feature of their CLL, which is called deletion 17p. They found a really good response rate, and in their early reporting, only 1 patient had disease progression after 12 months. The side effects were limited down to 25%, and I think that this is really a combination to watch, especially for people who have high-risk disease called deletion 17p. And longer follow-up, the study is needed to understand the true rate of how long people can remain without disease after they get a response. Another really important study that just was presented is called the CLL 13 study, and in this patients who had never been treated for CLL before got randomized to receive chemotherapy with FCR or BR versus venetoclax and rituximab, that anti-CD20 monoclonal antibody, venetoclax and obinutuzumab, another anti-CD20 monoclonal antibody, or the 3-drug combination of ibrutinib, venetoclax, and obinutuzumab, followed by ibrutinib maintenance. So the 2 arms that seem to be the best on this study so far are the bottom 2 arms. So the Ven-O and the 3-drug combination had better rates of MRD undetectability than any of the other arms. There were more ibrutinib-related side effects like AFib, bleeding, and infection in the 3-drug treatment. So of course, some looks like both arms are very effective. There are more side effects by using 3 drugs in combination. And so what to note is these targeted therapy does allow for deeper responses. The progression-free survival extended follow-up is likely presented this year. We have a big meeting coming up at ASH. It's called ASH, or the American Society of Hematology meeting, and we'll likely get an update of this study in December of this year. Interestingly, this venetoclax plus rituximab didn't do quite as well as expected. And so usually in second-line therapy for CLL, we recommend rituximab instead of obinutuzumab. However, in this case, it does look like obinutuzumab is probably a better antibody causing deeper responses. And so when I am able, I do use obinutuzumab in all lines of therapy right now if I'm able. Some insurances don't approve it yet just because there's not a lot of data in the second-line setting. I mentioned earlier that I wanted to talk briefly about early treatment for CLL. I'm lucky to chair this large nationwide study that is called the S1925 Evolve CLL study. What this does is it looks for people who have really high-risk features of their CLL. So that could be deletion 17p or a combination of clinical and genetic risk that's called the CLL IPI score and can be calculated by your doctor. These patients must have been newly diagnosed with CLL within the last year, so 12 months. If you enroll on this study, you get randomized, meaning the computer chooses if you would start treatment right away with obinutuzumab and venetoclax versus waiting until a time when you develop symptoms, which is the current standard of care. This trial, I think, is highly beneficial to patients because the drugs are fully paid for by the study, and it's asking an important question. I think it's often scary when your doctor sees you, they diagnose you with a new type of cancer, they do some labs, and they tell you, hey, you have really high-risk disease, we need to watch your CLL closely. Well, this gives the opportunity to say, hey, is earlier treatment when you have a very small amount of CLL cells, is that better so we can knock out the disease and have the longest time possible before that disease comes back or causes any problems? This study, as I mentioned, is open nationwide. And so if it is not open at your office, you can ask your doctor. They can find this, you or your doctor can find this on a website called clinicaltrials.gov and find the location closest to you. So what new agents should we be watching? And there are a few that I'm very excited about. What's important is these drugs called BTK inhibitors, sometimes they stop working. And the most common reason why they stop working is because the cancer mutates to become smarter than the drug. And so what I want you to think of is there's a spot called C481, and that's basically the keyhole. So that's the spot on CLL where the BTK inhibitor binds. What happens is just a slight change in the keyhole, and so that BTK inhibitor can't bind very well anymore. However, it does bind a little bit. And so usually what you see when the drug stops working is your lymph nodes just start to get ever so slightly bigger. Your white blood cell count gets ever so slightly higher. And you can tell that the drug isn't working quite as well anymore. However, I assure you that the drug is still working because if you stop the drug suddenly without your doctor's advice, often you will have rapid progression of your CLL. And so don't discontinue without another plan. And this particular method and mechanism of resistance applies to ibrutinib, acalabrutinib, and zanubrutinib. So what do we do about it? Well, there's a really exciting new drug called pirtobrutinib, or LOXO 305, that's been studied in a large group of patients that have been previously treated for their CLL or SLL, called the Bruin study. And this is a pill drug and is given by mouth daily. What's really exciting in this population of folks who have already had a lot of these other treatments, they still had a great overall response rate. 70% of patients were able to respond. And even in patients who have had 5 or more prior treatments, people can go for over a year and a half on this drug doing really well. And the progression-free survival remains the same regardless of that BTK mutation status, indicating that this drug actually binds in a couple of different spots. And so even that mutation can't stop this drug from working. Another thing that's really great about this drug is it really doesn't have a lot of side effects. And so I think it's going to be a really great option. You're going to see it a lot more often in folks with CLL. So what to know, this is really a drug to watch. There are combination studies with this drug that are ongoing. It's not yet available for prescription, but it is going up for approval in a different type of cancer called mantle cell lymphoma, and that's probably going to happen in December or January. And if it becomes approved for mantle cell lymphoma, sometimes your doctor can get these drugs available, what we call off-label use. So like, for example, if you don't have any other options left to treat your CLL, you can get these even though they're not approved for CLL. Another similar drug is called nemtabrutinib, or it was formerly called ARQ-531. There's a nice study looking at a similar population where this drug is given by mouth daily. Overall response rate is about 50%, and responses were seen in patients previously receiving the other BTK inhibitors. There really are minimal side effects with this drug too. The most common ones I see are fatigue, constipation, taste disturbance, or cough. Again, this is another really important drug to watch, and we need longer follow-up with the study to tell us who are the best treatments, who are the best patients to receive this treatment. And again, not yet available for prescription yet. So a totally different approach to therapy is something called CAR T-cell therapy. You probably hear a lot about it in the news because it's a really new and exciting treatment. So this takes advantage of the fact that our immune system can be used to fight cancer. And so what CAR T does is it really activates the immune system and allows for the immune system to recognize your cancer. What this looks like for a patient, starting on the upper left-hand corner, is your own blood is collected. An important part of your immune system called T cells are actually taken out, separated, and a vector is inserted into those T cells. And that vector is what's going to tell those cells to go after something called usually CD19 that lives on the surface of your CLL cells. Then we multiply those cells in the lab, and then coming back to the patient number 5 here, the chemotherapy is given, and then the CAR T cells are returned to the patients. This is a really interesting way to use your immune system, but also you know that when your immune system gets overactivated, like for example, when you get COVID or the flu, you know that things can happen like fevers and body aches and low blood pressure. And that's something we sometimes set off that part of the immune system too. So important side effect to know about is something called cytokine release. This also can, these cells can also penetrate into the brain and spinal cord, and there can be toxicity called brain toxicity, which can be mild, like mild confusion, or it can be more severe. These can be treated with steroids or decreasing the immune system or other drugs that we have, but can be scary. And so that's why this treatment hasn't rolled out for everyone yet, because there are still important side effects. And so we want to really carefully select people who are able to tolerate these kind of side effects before giving them. There's an important study called the Transcend CLL study that we ran part of this here at University of Utah, and it's been very exciting to see that you can combine this drug with BTK inhibitors. And when we did that, the overall response rate to therapy was 100%. 86% of people were able to achieve undetectable MRD. And there were, so grade 3 or higher means pretty severe toxicity. This cytokine release was only seen in 4%. There were 17% of people who got neurotoxicity, but again, that's something that does recover over time. This is a really promising therapy, especially for folks who have high-risk CLL or maybe CLL that hasn't responded to a lot of other treatments. It's kind of considered an alternative to a bone marrow transplant. And really, I'm looking for this agent to be approved. It is approved for other types of lymphoma, but for CLL, most likely in the next couple of years, it will be approved as something that we can offer outside of a clinical trial. And so really, I hope today what you have learned is just a brief overview of what is CLL and SLL, the current treatment options, and how to manage some of those side effects, and some of the new and emerging treatment approaches. So now, I'm really going to turn it over to Jessie so she can tell me what questions you guys have asked during this presentation, and I'd be happy to spend some time answering questions.
Wonderful. Thank you so much, Dr. Stevens. It seems like a lot of you have already started submitting questions via the chat feature on your screen. So I'm going to start with the first one. Can you go over the differences in terms of, and I know some of these might be slight repeats, but if you could just kind of elaborate a little bit, can you go over the differences in terms of expected treatment and prognosis for MDL versus CLL? I am very borderline and have trouble understanding what to expect. I'm also very young, 44, so again, not much info around for folks my age.
This is a really good question, and just a little bit of a typo because it should be MBL. And what MBL stands for is monoclonal B-cell lymphocytosis versus CLL. So essentially, I made the distinction between CLL and SLL. There's another term I didn't talk about called MBL. What this means is that you have no enlarged lymph nodes, no enlarged spleen or liver, but you can see these abnormal CLL-like white blood cells floating around. They're just at a level that is less than 5,000. And so really it's just a very, very low level of disease. Now, what is the quoted percentage is 1% per year will have enough CLL cells to be counted as CLL instead of MBL. So that's why your doctor is kind of monitoring. And what I often do for patients who have MBL is I monitor their blood counts and also their flow cytometry, so I know exactly how many cells they have. Really, it's actually the same disease, however, just a very, very small amount of it. So it's not technically considered a cancer because very often patients can live out the rest of their life without ever having CLL or needing to do treatment for CLL. And so it's just really very low level, tells us it's very limited in terms of, it's not very aggressive. And so I do counsel my patients very similarly to how I counsel folks who have CLL in terms of, you still have some increased risk for infection. And so I make sure patients are vaccinated. You do actually also have increased risk for second cancers, CLL or MBL. And so I make sure that patients are getting routine cancer screenings, including skin cancer checks, which is actually the most common type of cancer that people with CLL get. And so I agree. I kind of do. I hear you, and I feel like you're probably in limbo a little bit about this, but essentially it means that you have very, very low level of these abnormal cells, and there's a chance that these things will grow so slowly that you never have to worry about them. Now, you did mention that you're a younger patient, and I know that's sometimes, hard to wrap your mind around because when you read about things like CLL, the average age of diagnosis is 72. So you have a lot more years for that risk of 1% per year to build up. And so, it is possible you might change over to CLL at some point during your lifetime. However, still applies that if you don't have any symptoms or other low blood counts related to your CLL, you wouldn't need to necessarily do a treatment for that CLL. I think it's really just a term that we use to describe really low level of disease that we expect to behave less aggressively and hope that people do really well with this and hopefully minimal impact on their overall life.
Great, thank you, Dr. Stevens. Our next question is, I know there are two reasons why patients who are not yet getting drug treatment may have low platelet counts. One is that platelets are not made fast enough, and the other is that the platelets are being pushed out of the bone marrow. Can you discuss these two reasons and why one would happen over another?
Yeah, I think this is also a really good question. And so there are a couple of ways, and I think of it as your bone marrow is the factory for all of your blood cells. And so you might have a production problem, meaning there are so many CLL cells in your bone marrow that your bone marrow just doesn't have enough room to make platelets. And so I think of that as a production problem. The other thing is a destruction problem, meaning that your bone marrow is making fine platelets. It's just your immune system has incorrectly recognized your platelets as something that it needs to get rid of. This is called ITP, or immune thrombocytopenic purpura. And the thing about that that's kind of interesting, I mentioned this is a cancer of white blood cells and, part of your immune system. So essentially your immune system is reacting against something that is in your own body, so called an autoimmune phenomenon. And interestingly, people who have ITP or this immune problem, sometimes they can go on with a stable low platelet, really your body is breaking down your platelets, but your bone marrow is able to compensate for that. And so maybe your platelet counts are a little bit low, like maybe they run around 90,000. But as long as they remain stable and unchanged and you're not having complications like increased bleeding or bruising, we don't necessarily need to rush forward with CLL treatment. Now, in that case, if your platelets get low, like if they get down below 50,000, or they're really low, sometimes they can get quite low, even down to 10,000. We might need to do a treatment specifically directed at suppressing the immune system to allow your platelets to not get broken down. We don't necessarily need to treat the CLL in that case, because if we can get it under control with steroids or things like rituximab, we might not necessarily need to fully treat the CLL. So usually the production problem happens later on in CLL, when you've had a lot of time for your bone marrow to kind of get built up with these cells. And so it's hard to predict, because some people have this autoimmune problem, some people never have it. And so there's just a couple of different reasons why you could have those low platelets. And so that's an important part of, for example, if your doctor sees that your platelets are low, they might want to do a couple of different tests, maybe do once a week blood tests and make sure they're not dropping off quickly. And if it's unclear whether it's an immune problem or a problem of your bone marrow being involved, you really have to do a bone marrow biopsy to figure out, is there just too much CLL in the bone marrow?
Great, thank you. Our next question is, what is your choice between zanubrutinib and acalabrutinib, and why?
This is a great question. Right at this minute, my choice really is acalabrutinib. And the reason why is because that's the only drug that's approved. Zanubrutinib is not yet approved for CLL. And so I don't typically use it unless there's no other options that I think would be appropriate. Now, times that I have used zanubrutinib are like if a patient has a side effect on ibrutinib and acalabrutinib. Sometimes you can actually give zanubrutinib and the patient doesn't have that same side effect. And so right now, mainly my use of zanubrutinib would be based upon side effect preference. However, when it becomes fully approved, I think that question is going to get a little bit harder. And I think, based on my experience, I find that patients treated with acalabrutinib have a little bit fewer side effects than they do with zanubrutinib. But it also depends on what side effects they are. Because it does look like things like atrial fibrillation are probably more common with acalabrutinib based on, cross-trial comparisons. And so it kind of depends on what side effect you're having. But at this time point, I would recommend acalabrutinib just because of the approval issue.
Okay, great. Thank you for clarifying. The next question, someone just wanted to say if you have any thoughts on how diet can make anything better.
This is such a great question, and I think a very common question that I get asked by patients. And there are a few things that have been studied. I will be honest that I'm not very impressed with any of the results, but I can tell you what's out there. There was a clinical trial that looked at using green tea extract and curcumin. And essentially the purpose of this trial was actually to lower your white blood cell count. And they found that these supplements can lower your white blood cell count. However, the thing I don't love about it is you had to use such a high dose of these agents that they often cause side effects. So, it's not just like drinking a cup of green tea every day. It's like drinking 40 cups of green tea a day. And that can cause a lot of GI issues like nausea and diarrhea, things like that. And it doesn't really kill the cells. It just lowers the numbers temporarily. And so I don't think that taking curcumin or green tea extract is harmful as long as you're taking reasonable doses. But I don't know that it's that helpful either. And so really just have to be wary. I think that there's a lot of companies and a lot of people that want to take advantage of folks who have cancer and say, pay a lot of money for my supplements and this will help you. And so just really, do your research if you're considering any of those supplements. Figure out what's really the data and really how that might help you. And make sure it's balanced with the cost of any of those supplements. The other thing that I often do for my folks is I check their vitamin D levels, because if your vitamin D level is low, for one, that can contribute to fatigue and joint aches and things that generally make people uncomfortable. But there is a little bit of data that when you start treatment for CLL, if your vitamin D level is depleted, then that might help you respond better to treatment. Now, there's a lot of, kind of things that we call can confound, or maybe there's some other factors that are at play here. But I think in general, even for bone health and for generally feeling better, repleting your vitamin D is a good idea. That being said, I think, those are the supplements that I think that have the most data. But of course, there's lots of things out there. And like I said, I would say just do your research and make sure you're not, spending all your savings going after the supplements if they don't have good proof that they can work.
Thank you. Our next question is, someone asked if I have CLL, is my son more apt to get it?
This is a question that is an evolving area of research. The current data show that probably about 5 to 10% of people who have a family member with CLL are going to also get CLL. I can sometimes pick out these families. Like, for example, I've recently seen a patient that she told me, my sister has CLL, my aunt has CLL, my cousin has CLL. Those people, I'm sure, that have some genetic predisposition, and that's somebody who I would refer to genetic counseling, because it might help to understand if the kids are at risk. However, it's not quite as easy. You guys probably have all heard about the BRCA gene, which is highly associated with breast cancer. Unfortunately, there's a lot of different genes that are associated with CLL, so it's not just as easy as doing one simple test to figure out if it's a genetic predisposition. The other thing I also like to tell people is it's kind of, I guess most cancers, you always hear people say, gosh, did I catch it early enough? And I often think that CLL is a cancer that we catch too early, because if you're not having symptoms and we're not going to do treatment, sometimes that just creates a lot of anxiety. And so we still don't recommend, even if we know that maybe you have a genetic predisposition, we don't recommend a lot of screening for CLL in your family members anyway, because if they have completely no symptoms and their other blood counts are normal, it might not be a benefit to screen them early for this type of cancer. So good question. A lot goes into that answer, I guess.
Great, thank you so much. I think we have time for a couple more questions. This question is, can you discuss bispecific therapies?
This is another good and exciting treatment that focuses on the immune system. And what a bispecific antibody means is we want to target something like CD20, like we mentioned that rituximab and obinutuzumab do, or CD19, like the CAR T cells do. And what we do is that one of those, prongs of that antibody, it goes after CD19, and it links it to something called CD3. That's on the surface of T cells, another important part of our immune system. So it basically is just bringing those cells closer together so that the immune system can recognize and kill that cancer cell. These bispecific antibodies have been tested pretty heavily in types of cancer, types of lymphoma, like diffuse large B-cell lymphoma or follicular lymphoma. And they haven't been tested a lot in CLL yet. But I'm very interested in seeing more research done in CLL. There's a clinical trial right now that's ongoing that uses mosunetuzumab, which is one of the bispecifics for folks that have CLL. I think we'll have a lot more information. All of these immune therapies, I didn't spend too much time talking about it, but the immune system is pretty weakened in folks that have CLL. And so, we're trying to stimulate that immune system to work better, but still we're kind of starting at a level of a not perfect immune system. And so these, like bispecific and CAR T, I find that their effects and they work better in types of cancer like diffuse large B-cell lymphoma, where the immune system is a little bit more normal at baseline. And so it still does have some dependence on your own immune system working. So I think it's very exciting. I think we need a little bit more research to know how to best use them for folks who have CLL.
Great, thank you. And our last question, someone had just asked a COVID booster question. They said they just received their second COVID booster and experienced very high fever that lasted 2 days. Is this common with CLL, or is this an aberration? So if you could just elaborate a little bit about CLL and COVID boosters in this situation, that would be great.
Yeah, and you guys have probably all heard that there's a new COVID booster out, which is called the bivalent booster. It essentially has more protection against the Omicron, the newer variants. And so a lot of folks are getting these because they just came out, and they are approved for anybody whose last booster was more than 2 months ago. So that's probably quite a few of us. The fact that you had a fever that lasted a couple of days is just that immune response that you're getting to the vaccine. I take that as a good thing because we know that your immune system did recognize something foreign coming in and is working to make a response to it. However, it doesn't totally correlate with the likelihood of your response. Like, it doesn't mean that since you had that fever, you'll have X many antibodies to COVID. It is a good sign, but it's not actually necessary to get the response. Doesn't mean that you had COVID, of course, because these are all inactive particles. They're not the actual virus. I think from my standpoint, the most important thing that I counsel my patient is there's a medication called Evusheld. These are injections that you get in your backside that last for 6 months and essentially just inject antibodies directly in. So your body doesn't have to do anything to make a response. So I'm recommending that my patients do that in addition to their COVID vaccines, because I find that people who, it's less likely that you get COVID, and COVID is less severe, particularly if you've had this Evusheld injection.
Great. Well, thank you so much, Dr. Stevens. This has been really informative, and we really appreciate all the time you took today. For everyone on the call, this is being recorded right now, and the recording will be sent out hopefully later today or possibly tomorrow, so you can review anything Dr. Stevens has to say. And we'd also like to thank everyone for joining us, as well as our sponsors, AstraZeneca, Genentech, and Pharmacyclics, for making this program possible. Please remember, if you have any additional questions, or if we didn't get to your question, or if you'd like to be connected with someone else who's been impacted by lymphoma, you can always reach out to the LRF helpline at 800-500-9976. I'd ask you to please take a few moments once you receive our follow-up email to complete our evaluation. These are very important for helping LRF to ensure we deliver the most useful and meaningful programming to you. And with that, I'd like to thank Dr. Stevens again, and thank everyone else for joining us, and to have a wonderful day.
Thanks everybody for joining.